I'm Professor Aziz-ur-Rehman, and in our last lecture we discussed acid peptic disease, and I mentioned that H. pylori deserves a separate lecture because of its unique pathogenesis and treatment. Uh, if you have H. pylori infection induced acid peptic disease, I believe the initial treatment may be the same with antacids or with PPIs or H2 blocker, but a formal diagnosis of H. pylori and its formal treatment in the form of eradication is important in some situations. Now, what is this bacterium? And I would go through little history and then the pathogenesis. This is the bacterium, which is spiral shaped with flagellae, with capability of producing many cytokines, many enzymes. One of them is urease. It was discovered in 1983 by two Australian scientists, and Warren and Marshall. They described it and they made the cause and effect relationship between H. pylori and the ulcer. It is acquired through oral route or fecal oral route. It is not exactly sure where it resides in nature, most probably in contaminated water sources and also contaminated food, but human remains the main host of this bacterium, and it could be transferred from oral like kissing, or fecal oral. Somebody is not very particular about his personal hygiene, hands may be contaminated, and then food may be contaminated, the water may be contaminated, and whoever eats that food or drinks that water gets the infection. Now, it lives in the mucosa of the stomach. Now, this bacterium, generally speaking, does not invade the mucosa. It just lives in the mucous membrane, and it is actually hides itself in that, and then it would be difficult to imagine how can a bacterium, a live organism, live in highly acidic environment of stomach. Now, most bacteria, they are killed by our gastric pH, but this bacterium is specially equipped with formation of ammonia. So ammonia being an alkali, so in simple words, this bacterium produces ammonia and carries a blanket of ammonia with it and survives in acidic environment. And it is also not exposed to the acid directly because it lives in the inside the layer of the mucus layer. It usually does not infiltrate or penetrate into the gastric mucosa, and it also does not cause bacteremia. It primarily affects parietal cells, but it can also affect G cells and D cells. G cells are gastrin producing cells, and D cells are somatostatin producing cells, or are related to our acidic pH. So that is how it leads to production of more acid, and also induces inflammation in the gastric mucosa and causes atrophy and gastritis. Because of the cytokines. So it induces inflammation and atrophy of the gastric mucosa. So that was the little bit of pathogenesis. What is the importance of H. pylori? May cause chronic atrophic gastritis and may be responsible for gastric ulcer, may be responsible for duodenal ulcer. There is very high correlation between gastric ulcer, duodenal ulcer, and H. pylori infection, and that may cause chronic dyspeptic state and may also be responsible for some nutritional deficiencies like iron deficiency. It may interfere with absorption of iron and vitamin B12 and some drugs. So that is importance of H. pylori infection. Another importance is that it may be responsible for non-healing or recurrent ulcers. Now, if you have duodenal ulcer or stomach ulcer, even if it is associated with H. pylori infection, the initial management would be effective if you give them antacid and PPIs. they would respond, and in many cases ulcer will also heal, but there is high chance of recurrence if H. pylori is not eradicated. More importantly, though not very common, but it could be responsible for adenocarcinoma of the stomach and maybe also a unique tumor which is maltoma. It is actually mucosa associated lymphoid tumor. So this could be actually caused by H. pylori infection, and it is also H. pylori infection is also associated with esophageal cancer, squamous cell cancer. So I think that this is, although luckily not very common, but since these are malignancies, that makes H. pylori infection very important. There are some extra hepatic manifestations also, though we are not exactly sure about the cause and effect relationships. So far, we only know the association, like idiopathic thrombocytopenic purpura may be associated with H. pylori infection, iron deficiency state, because iron needs acid to be absorbed. Similarly, vitamin B12 deficiency, and it is also associated with ischemic heart disease, and that this relationship is not exactly clear. Maybe since it is chronic inflammation, H. pylori causes chronic inflammation in the stomach, and chronic inflammatory state we know is associated with high incidence of ischemic heart disease. It may also cause what is called coronaritis, that means inflammation of coronary arteries. Much of this is actually speculation, but we know it is responsible for non-healing or recurrent ulcers and also these malignancies. So that deserves a specific treatment of H. pylori infection. What are the symptoms if somebody has H. pylori infection? The symptoms are the typical symptoms of acid peptic disease, which were discussed in last lecture. Maybe nausea, maybe vomiting, maybe abdominal pain, or dyspepsia, maybe heartburn, that is retrosternal pain. In some cases, maybe diarrhea, and there may be hunger in the morning, and there may be halitosis, bad smell in the breath. So I think all these could be responsible for or may be caused by H. pylori infection. Now, I think that brings me to a very, very important topic, that is the diagnosis, how we establish the diagnosis of H. pylori infection. There are several tests. First of all, simple to do is anti-H. pylori antibodies. Any chronic infection may cause formation of antibodies. And the problem is that there are many people who have antibodies. I will discuss this in more detail in subsequent slides, but antibodies may be present in those who have actually recovered from H. pylori infection, and they may not have current infection. Then we have stool for H. pylori antigen. Then we have urea breath test, very interesting test, and I'll explain how this works. And then biopsy, urease test, and endoscopic biopsy. I think these 5 tests, if used judiciously, that gives you a very, very accurate diagnosis, and then you can take the next step. So I'm going to now discuss these tests one by one to highlight their merits and demerits. First of all, anti-H. pylori antibodies. It's very easy test because patient will simply give blood sample and the test will be done within hours. It is used for screening purposes. So a negative test would rule out chronic infection. I believe a very acute infection test may still be negative, but since these patients, they present with chronic symptomatology, so negative test would rule out H. pylori infection. That is the value of this test. Does not differentiate between current and past infection. Those who have recovered from H. pylori infection naturally or due to medication, they will still have antibody test positive. So it cannot rule out, it cannot differentiate between current infection and past infection. So on the same token, it cannot be used to check the response of the treatment. Now, before treatment and after treatment, irrespective of the result, the test will remain positive. So these are the limitations. So primarily, this antibody test is used as a screening test to rule out H. pylori infection. If the test is positive, then patient would need further tests to see if the infection is current or old. Then another test which is I think very popular is stool for H. pylori antigen. Live H. pylori in the stool is not easy to be identified, but its antigen can be detected with molecular technique. So it is cumbersome because patient will have to give stool sample. Patient will have to wait when he or she passes stool. So it confirms current colonization oblique infection. Now, why do I use two words? Infection obviously means that patient has H. pylori and there is inflammation in the stomach. But there are people who do not have any symptoms. They may still harbor this bacterium in the gut, in the stomach, so that will also be detected. Now, it is not exactly clear whether these patient, asymptomatic patient with H. pylori colonization should be treated or not. It is very specific and very sensitive test. So these two features combined makes it the test of choice used to confirm eradication. So once patient has received complete eradicative antibiotic course, then we do the test again and then see if if the antigen has disappeared, that would indicate the treatment has been successful. One point I'd like to make it here is that once the treatment course is completed, you have to wait for at least 2 weeks and patient should not be on PPIs or antacid. Only then test will become valid. Otherwise, this will maybe false negative. If you do the test while patient is in H. pylori, the test may be false negative. And it has got wide availability. All leading laboratories, they do it. So I think that is why a very high sensitivity, specificity, and wide availability and its ability to be used as diagnostic test as well as a confirmatory test after eradication, I think that makes it the investigation of choice for those patients, for most patients. Now is the urea breath test. This is very popular test, though in Pakistan it's not available mostly. It's available on very selected places, but it's very interesting. I like to explain the mechanism of this test. I think I need your attention. So patient is, wherever you want to do the test, patient is suspected to have H. pylori infection and patient is given this milk-like thing which has got urea dissolved in water. But this is not ordinary urea. This is urea which is specially made for this purpose. And this urea has got carbon, which is carbon 13, which is actually a radioactive carbon which can be traced. So the difference between ordinary urea and this urea is that the carbon in this urea is carbon 13, which can be detected by special equipment. So patient is asked to ingest this, and after that, if patient has infection with H. pylori and if H. pylori is present in the stomach, it would split urea into NH4 and CO2 because H. pylori produces urease. There are other bacteria that can produce urease, but uh, it's only the H. pylori which has the capability of surviving in the gastric mucosa. So if we can detect some organism which has the ability of producing urease, we will assume that this is H. pylori. So if there is a urease producing organism, it will split urea into NH4 and CO2. If this patient does not have H. pylori, this urea will pass on as such into the stool. So NH4 and CO2 are formed. NH4 will be excreted. CO2, C is marked red because this has C13. So this will be absorbed into the circulation and will mix with body pool of carbon dioxide. And normally carbon dioxide is excreted through the lungs, and this carbon dioxide will also be excreted through the lungs and it can be detected. Patient is asked to exhale into an equipment and where this carbon dioxide is trapped, and if then later tested, if that shows radioactivity, that would mean that carbon dioxide which was initially part of this urea was split into carbon dioxide and then excreted. So all this would mean that there is something in the stomach that has splitted this urea into ammonia and carbon dioxide. And what is that something? It is a bacterium, and the only bacterium which can survive in the stomach is H. pylori. So it's kind of confirmatory test, but the confirmation is indirect. We call it urea breath test. Very popular and can be done easily, and I think it's widely available in other countries, but not in Pakistan. So indirect confirmation of active colonization, it would not be positive if somebody had suffered from this infection in the past. It would only be positive if H. pylori is present live in the stomach at the time of test. Can be used to confirm eradication also. Again, the same principle should apply, that once you have completed eradication course, 2 weeks later, when patient is off PPI and not taking antacid, then test should be performed. And it's easy and reproducible, but not available everywhere. So otherwise, it's a good test, but the availability is the problem. So this covers 2 tests: antibody test, stool antigen, and urea breath test. 3 tests actually. Now let's move on to another test. And this test is called biopsy urease test. Now this is also based on the urease principle, but this test is done on biopsy specimen. So patient undergoes a gastroscopy, endoscopy, and then biopsy is taken. That is used to perform this test. Now this is actually a buffer solution. In acidic pH or neutral pH, it would have this color. And if you make the pH alkaline, it would turn into pink red. So this is the basic physics or the chemistry behind this test. So patient's biopsy specimen is put into this and kept for some hours, usually for overnight. And if this biopsy specimen has H. pylori, that would produce urease, and urease will make the production of ammonia, and ammonia will make the pH of this fluid alkaline, and this indicator becomes red-pink in alkaline environment. Now, of course, if you add any other algae, it will change the color. But since in our test we have just put biopsy specimen, and if the color changes, it would imply that the pH has become alkaline, and that would imply that ammonia has been produced by H. pylori. So I think this is another confirmatory test. But you will need to do biopsy. I think this test is not exactly very popular these days, because once you do biopsy, then you can detect H. pylori on histological examination. That is obviously more definite. So that brings us to a most definitive test for H. pylori infection, that is endoscopy. And there are various patterns of gastritis, atrophic gastritis, and there are regional type A, type B, type C gastritis, and duodenal ulcer and gastric ulcer, and other condition can be there. So I think this is just one sample of this inflammation. This is pylorus, and you can see these patches of inflammation. Now, but I'm going to show you various patterns which are possible in H. pylori infection. There may be chronic gastritis, maybe atrophic gastritis, maybe intestinal metaplasia, dysplasia. This you will be able to detect only on biopsy and histological examination. There may be gastric adenocarcinoma. Of course, if you see a tumor, you will take a biopsy, and then that will be examined under microscope. And maltoma, mucosa associated lymphatic tissue lymphomas. These two would obviously be rare, and these two are the commonest appearances on endoscopy. So when we take biopsy, not only we look for these histological changes, we also try to identify H. pylori in the biopsy specimen. Biopsy is typically taken from the antrum. Even if somebody has duodenal ulcer, the biopsy is usually taken from the antrum, because the H. pylori loves to stay in the gastric mucosa. It usually does not invade duodenal mucosa, only because unless there is gastric metaplasia in the duodenum. If in some cases the mucosa of the stomach can go into the it could go into the duodenum, and then H. pylori can also go to the duodenum. But biopsy is usually taken from the antrum. Whether patient has got gastric ulcer or patient has got duodenal ulcer, the site of biopsy is usually the antrum. We typically take multiple biopsy, and that shows these features, and also we can identify the bacterium. An endoscopic biopsy, H. pylori can be identified with the usual H&E staining or special stains called Giemsa stain. I think this can be done, and culture and sensitivity is possible, but usually difficult. I understand this bacterium is not easy to grow in a laboratory environment, but if you can do the culture and the sensitivity, you would be sure which antibiotic will be useful, because this bacterium is very clever in mutations, and it has developed a resistance to many antibiotics which we used to use, but they are not very effective these days. Like, it has acquired resistance to metronidazole, it has acquired resistance to clarithromycin and other antibiotics. Molecular tests can also be done. So like PCR test can also be performed on biopsy specimen, and you can identify antigens of H. pylori. So these are the tests which can be done on biopsy specimen to make a final diagnosis. But of course, the most definite would be the seeing of bacterium itself. Like, this is a biopsy specimen, and this is typical pit which has got multiple cells. It has got parietal cell, it has got chief cell, it has G cell, D cell, other cells, and in the lumen of this gland you can see these small dots. These are H. pylori bacteria. Now, the third part, first part of my lecture, I discussed the basics of H. pylori. In the second part, I discussed the diagnosis. I went through antibody test, stool test, urea breath test, biopsy test. Now, that brings us to the last component of my lecture, that is the treatment. Now, I think first question is, should we treat every positive case of H. pylori? I think the answer is not simple no or yes. We have to compare pros and cons of treatment, and then have a discussion with the patient, and then decide whether or not to treat. Why this question? Because there are some pros and cons of treatment, and I'm going to show you the pros and cons. Let's first examine pros. If H. pylori is eradicated, the recurrence rate of ulcer becomes very low. So that is the advantage. And prevention of cancer is also possible. At least we would hope that after H. pylori infection, H. pylori associated cancer would not occur. Then psychological relief for the patient. I think this is important. Knowing that the infection has been eradicated, I think that would give you a psychological relief to the patient. And risk of transmission to others. If you have cured a vector, cured an index patient, then transmission of the bacterium to others will also be minimized. So these are all pros of infection. I think you would be probably convinced that all patients should be treated. But let me show you the cons. Many positive cases are asymptomatic. There are people who have H. pylori colonization in the stomach, but they do not have any symptom whatsoever. So it definitely would be difficult to convince these people that they need treatment, so that they cannot transmit infection to others. So I think patient will not be keen at all, and especially when we know that there are some unpleasant side effects. There is no 100% effective treatment. There are various regimens effective from 60 to 75, 80%, but none of the regimen is 100% effective, and all are associated with unpleasant side effects, because this usually involves 2 or 3 antibiotics with bad taste in mouth and GE upset. So Nobody wants to take antibiotics without any reason. So I think that is another reason why we should not treat every patient. Then recurrence from the same source. I think this is the biggest point against routine treatment. If somebody has a contaminated source of water and you eradicate the infection, and the person is going to go back in his community and going to consume the same water, and patient is going to get the same infection again. So unless you can make sure that patient would be not drinking sterilized water, treatment of H. pylori may not be of any point. So I think there are lots of cons and there are some pros. You have to decide on patient to patient basis. I think then you can, that is the best way to go. You know, antibody test is positive in, like, according to your age. If you are 70-year-old, then there are 70% chances that antibody test is positive. So antibody test should not be actually used for the used as an indication of the treatment. Now let me go through some treatment regimens. There are several regimens available. Now this is very simple principle that if you have multiple regimens available for one particular condition, in this case infection, that obviously it implies that none of them is excellent. Otherwise that would say all other would disappear. None is 100% effective, none is clearly better than other, all have unpleasant side effects, and PPIs or PCABs are always part of the regimen because these antibiotics, they need PPI and PCABs to be effective. Now let me show you some of them. There are at least 8 regimens. I think I've gone through at least 8 of them, but I will not include all of them in my lecture because those who are interested, they could refer to some textbook or other media. So, but I'm going to just discuss 3 regimens: the triple regimen and quadruple regimen and sequential. Triple one, this is the most conventional. A triple regimen would mean 2 antibiotics and 1 omeprazole. All right. So omeprazole is given 20 milligram twice a day first 2 weeks, followed by once a day next 2 weeks. This is the common to all regimens. And then we give amoxicillin 1 gram BD, that means 500 milligram capsule, 2 capsules morning to evening, and clarithromycin 500 milligram BD. So that makes a triple regimen: omeprazole, 1 antibiotic, another antibiotic, triple regimen, and this is for 2 weeks. Many textbooks would say 10 days to 15 days. I mostly prescribe it for 2 weeks because in Pakistan resistance is high and we do not have access to culture sensitivity and resistance testing, and we do not have local data. So I think I would give it for 2 weeks. Unless patient cannot tolerate it for 2 weeks, I usually prefer to give it for 2 weeks. So this is the triple drug regimen. Then we have quadruple, easy. This one is the same, and this one is the same except that you add bismuth subsalicylate, 2 tablets 3 times a day, and this is also for 2 weeks. So I think this triple, when you add bismuth, becomes a quadruple. There are some other quadruple regimens also, but this one is one of them. Then sequential. Sequential is very interesting, and here you also use omeprazole the same way, but first 5 days, it is 10 days course. Day 1 to 5 you use amoxicillin 1 gram BD only. So along with omeprazole, you use amoxicillin 1 gram BD for first 5 days, followed by clarithromycin 500 milligram BD and tinidazole 500 milligram BD for next 5 days. So sequential 5 days followed by 5 days. Now this may be easy for patient to tolerate, and the philosophy is that before you give clarithromycin and tinidazole, which is going to clear the bacterium is weakened by amoxicillin because amoxicillin uh, will make the cell wall weaker, and then clarithromycin and tinidazole will penetrate into the cell better and will kill the bacterium. So this is sequential. Now, it is not actually possible for me to tell which one is the best. I think mostly I try this one as a first line of treatment. If somebody does not tolerate, then I seek for the other regimens. Okay, retesting. Now, once you have given the complete course, should you retest? I think, well, it makes a lot of sense. Patient would want to know if the treatment has been successful, and physician would also like to know if the treatment has been successful, if the bacterium has been successfully eradicated. A best test for retesting is urea breath test and fecal stool antigen, because these two tests, they detect the actual live bacterium in the stomach. Antibody test is not good for this, and endoscopy I think is difficult. Patient probably would not want to undergo endoscopy again. Maybe in some cases you would like to do endoscopy, but I think urea breath test and fecal stool antigens are best tests, and I've already told you that this test should be done at least 2 weeks after completing the therapy, and patient should be off H. pylori, or patient should be off PPI and antacid. Now, in some cases, I think I forgot to mention earlier that PPIs have been the treatment of choice, but there is some data that these new anti-secretory agents, the PCABs, potassium competitive anti-secretory agents like vonoprazan, that may be actually more effective. There are some trials which indicate that instead of omeprazole or any other PPI, if you use vonoprazan, the success rate is increased. Patient should be off these agents when you perform that test. Now, what if the test turns out to be positive? Then perhaps it would mean that the initial treatment has not been successful, and maybe you can now try with another regimen. Unless you have the culture and sensitivity report, you will probably try a more harder regimen. If initially you had given triple regimen, maybe now you will give quadruple or maybe sequential. So that brings me to the summary slide. H. pylori infection is very, very common. At least the antibody test is extremely common according to your age, and even the actual infection is very, very common. And eradication should be considered in appropriate cases. As said, you will need to have a discussion with the patient, and you will discuss pros and cons and then decide if the treatment is needed. And pros and cons of treatment should discuss with the patient. Several regimens are available. Choose the one according to local sensitivity pattern of H. pylori. Either you have specific culture sensitivity report of that patient, that would of course be great. Otherwise, if you know the local data, if you know that in certain geographic area there is a resistance to metronidazole or resistance to clarithromycin, those agents should not be used. And gastric maltoma is a definitive indication for H. pylori eradication. In others, I said pros and cons, but if somebody has gastric maltoma, I think that is one definite indication for H. pylori eradication. Of course, this patient would probably need other treatment also, but H. pylori must be eradicated. So that completes this lecture on H. pylori infection. I hope you found it useful, and I really look forward to see you in my next lecture. Please join my channel Medurstand. It is free, and it's going to be free forever. And I'm going to leave the link below. Thank you.